Welcome to Live Better Without Surgery. I'm Dr. Joe Albano, your guide to exploring the innovative world of regenerative orthopedics. We uncover non-surgical solutions that give you hope to move better, feel better, and live better without surgery. Let's get started. Today's episode is entitled, Why Be Normal? And here with me today is Merin Kinikini. I'm going to let her introduce herself, but just in ways of background, she's been working with me. We've been working together since 2018. We were talking about that before. When did we really start doing this together? It was 2018 when we were over in our Cottonwood office. And she has been instrumental in helping us implement our programs, and specifically the bioidentical hormone replacement therapy programs, and optimizing all of the people before we do any of the regenerative things. So today we're going to be talking about why be normal and optimizing hormones through using bioidentical hormones. And also we might talk about some supplements in here as well. But it's just one part of our comprehensive program for optimizing people's health. And so to start with just some of the general things that people will think about when we're thinking about hormones and optimizing them, or fatigue. Like, are you struggling with being tired all the time, even after a full night's sleep? A lot of times this will involve women. Guys get it too, but women seem to have this more commonly. And there's lots of reasons to be fatigued. And we'll talk about that more. How about, is it harder to lose some of the extra weight? You've been eating the same amount, you've been really good with your diet and exercising, but as you get older, it's harder to lose those pounds. What about that? That's a common question too. How about being more productive at work because you just don't have the energy, you can't concentrate so well? These are all common things that people will bring up, but I am going to give it over to Merin right now and have Merin just introduce herself and see how we can delve into this subject of optimizing our bodies, but specifically hormones, and that normal is just not optimal. So, Merin, tell us about you.
Thank you. Yeah, I'm Merin Kinikini, and I come initially from a traditional background of medicine, have some degrees in medical dietetics, nursing, and a nurse practitioner. And then I did some extra specialization and certifications in functional medicine and bioidentical hormone replacement therapy. And I got the most involved with hormones when I started working with Dr.
Can
Albano.
we go back, Frank? Kind of glossing over. You have like lots of letters after your name. So you're a DNP, Doctor of Nurse Practitioner. People might not know what that is. Tell people what that is and what you had to do to get that, because that's kind of important. It's a big deal.
It's a clinical doctorate. It takes a little less time, but when I did it, it was about 3 years in addition to a master's degree and a couple of bachelor's degrees. And when I did it, it was through the nursing, through the Department of Nursing. But I did a lot of my projects in nutrition because that was my original background. So,
Because you were a
because I
dietitian
was a
before
dietitian
that.
first, so I did ketogenic diet therapy and weight loss and all of that as part of my doctoral project.
Nice. Okay. So basically, you told me you're a nurse doctor.
I'm a nurse doctor. Yeah.
Got it. Didn't want you to gloss over that. Keep going. Okay.
Okay. So through all the traditional training I had, including my functional medicine training, I felt like was not satisfying. It was glossed over. It There wasn't a lot of in-depth information. There wasn't a lot of studies discussed, and so that was an area I felt kind of lacking. That I just didn't know enough information, and I was coming into menopause myself when I started working with Dr. Albano, and he had done some courses through World Medical and was very impressed with all the research in the background and the ways that hormones could help with not only the regenerative side of medicine, but also just lifelong goals for patients. So I went through all the training as well, and I was hooked. And so I've been part of this program for the last 8 years for those reasons, and I benefited from myself from hormones, and then I'm happy to discuss and help patients go on hormones for all the different health benefits they offer.
It's just so good. It is truly optimizing our bodies. And that's what we're all about here. And I know you are too. Me personally, I am as well. Like, I just want to be optimal. I don't want to be normal. I don't want to be okay. And so maybe we should talk about that just briefly. So if you're listening to this, you can't see my hands here, but basically, if there's a low and a high level of whatever hormone it is we're talking about, if you're below that low level, again, for whatever hormone, doesn't matter. It's all the same. If you're below that, most every doctor in the world is going to go, yes, you should be on that hormone. Let's give you some. And then if you are just slightly above that, you are in the quote normal range. Most doctors, and the way I was trained, and Merin was trained too before we started learning about this, but in my med school, residency, fellowship, I wasn't taught any of this stuff. Where, okay, if you're just above the low level of normal, that it's normal, leave it alone, you're good to go. But doc, I'm still tired, or whatever your symptom is. And if you bring that level up to a high normal level, that is optimal. And a lot of times the symptoms will go away. But even if you're looking at another hormone and you're not having symptoms, it's just good for your health for lots of reasons, like decreasing cardiovascular risk, for instance. So that's the principle of optimizing. So, Mary, give me some examples of common issues. So, what people will have, why are they coming to see you?
Yeah, there's a variety of patients that will come and see me, and they may be in different stages of life, and so they may have different types of symptoms. So, in women, let's say, for instance, they might not quite be menopausal. They're still, having some periods, but they are having weight gain, fatigue, poor sleep at night. They have very low libido, and they just don't feel well. They have brain fog. They don't feel like they normally used to feel. And so in those patients might be more interested initially in just treating the symptoms and just feeling better, sleeping better, overall just functioning better day to day. And then you move into that benefit as well as the potential long-term benefits that you don't always see right away. But if we can continue to fine-tune these hormones, get them in, like Dr. Albano about, in an optimal level, and we consider optimal not just what labs are, because labs can be not accurate. Labs a lot of times reflect what the norms of everybody that's had that lab drawn. And so we also look at what research has shown to be protective and protective for bone health. So not having osteoporosis, cardiovascular health, minimizing risk of diabetes, dementia. Like, there's a Cache Valley study done here in Utah that showed if you were on hormones for greater than 10 years, you had an 80% reduction in Alzheimer's. So there's so many health benefits that someone could get. And so it's really looking at what symptoms do they need to manage short term, and then what are their long term goals to remain healthy for as long as possible.
So, you mentioned being on hormones. Let's clarify what that is. So, what's the difference between synthetic and bioidentical hormone?
Yeah, it's a big difference. So synthetic hormones are the hormones that are manufactured. They're not hormones that our body naturally makes. And the two common ones out there, one is conjugated equine estrogen that is made out of horse mare urine, and it consists of a lot of chemical structures that our bodies do not have, and it also has about 15% estradiol, which is what our body does make. The progesterone that is used is artificial progesterone, and it has never been seen by our body in any kind of natural way. And so when you give those types of hormones, you get different effects. The receptors aren't the right receptors. You're putting a square peg in a round hole, and it definitely causes a lot more side effects and not the benefits that you see with the hormones that our body naturally makes. So that's the
So,
goal.
horse urine, just wanted to clarify.
Yes.
Horse urine, synthetic
Yes.
estrogens. And so, we as physicians and nurse practitioners, we will oftentimes not be very clear when we're talking to patients. So when we say estrogen, What does that mean? It could mean synthetic estrogen, horse urine estrogen, or it could mean bioidentical one. So when we're talking to our patients, we're trying to be clear, like, okay, it's not the horse urine estrogen, it's the bioidentical. And so big difference. So that's important for everybody to understand. When we're talking about hormones here, we're talking about bioidentical hormones.
And I think to clarify for this audience as well, when you are looking at hormones on the internet and you type in estrogen or progesterone, you're going to get everything. So even the FDA doesn't necessarily separate out estradiol versus the conjugated equine estrogen or Premarin, or nor do they separate artificial progesterone with micronized progesterone. So you might see all this conflicting information, and it gets really confusing because you're not seeing the pure studies and the research that are done only using the bioidentical hormones.
So where can you get the bioidentical hormones from?
The best place to get these are from compounding pharmacies, and these are reputable compounding pharmacies that are they're checked. They know they have um, pure grade compounds. They make them in a very sterile way, and so they are incredibly safe.
People might not know what's a compounding pharmacy.
It's basically, if you think of the old time chemists, back in the day that were in the back room, like kind of making up the medications, this is what they do. And they're very good at it. They're very skilled and very knowledgeable about individual doses. Like if you need, if you're allergic to ingredients that might be in a regular medication over the counter or like through the regular pharmacy, they can make it specially for that. They can make different types of dosing, different ways to take it. So they can get really creative as far as giving you the right plan.
When we write the prescription for everybody so they know how this works, then we write whatever it is, for progesterone, the exact dose. These compounding pharmacies will create that just for you, the patient, specifically. So they don't have a stockpile of all these things sitting there. They make it, compound it specifically for each one of us, the patients. And I think that's a good thing. So this is totally the opposite of big pharma. We won't really delve into that right now because that can take a long time. But it is not big pharma. It's the opposite of that. That doesn't mean it's not safe because that's one of the things that I was taught back in the day in my training that these compounding pharmacies are not getting good quality ingredients. You don't know what you're getting. You need to get something from a quote reputable pharmacy, big pharma, and use their products. That's just what I was taught. You probably were taught the same thing, but that's absolutely not true. These places are really safe, and I think better than the regular. But you can't even get these medications. Most of them. There's a few you can get from regular pharmacies, but most of them you just can't get.
Yeah, there's a few kind of main ones that you can get from a regular pharmacy, and if you're one of those patients that prefers to go that route to try it, and you don't need specialized dosing, we can work with you on that. But the reason why also that we know these compounding pharmacies work is because we check labs and we check your blood levels and we make sure that it's working in you. And so, therefore, we're working with you and the pharmacy together for the right plan of care.
Okay, so summarize. What are the big problems that you see? Why do people come to see you?
They they may have all the things that you've already mentioned. They feel off. They have brain fog. They're tired. They're gaining weight. They have irregular bleeding is one that's common. That's really annoying to women, where you have a period that lasts 3 weeks and then you skip, and where you have a lot of pain and migraines and problems around your period. For men, it's decreased energy, fatigue, loss of muscle mass, low libido, and low libido is in both men and women.
Important. I was going to ask you about that one. What about the typical age? What kind of person are you seeing? Men, women, what age?
We'll see all ages, honestly. I've seen younger women that maybe might be having a different issue, right, than a menopausal woman. But women, this is an interesting fact I didn't realize until I learned about it, is that women have more testosterone in their body than estrogen in their prime. So in their 30s, 20s, 30s, women actually have higher levels of testosterone than estrogen in their body in terms of what's there, and that estrogen is part of the estrogen is made from testosterone. So when women start to lose their testosterone in their 30s, a lot of times that's when it kind of starts to dwindle. Then they're going to notice, the low libido kind of happens first, and they don't recover very well from their exercise. They're losing muscle mass. And of course, there's a lot of reasons for low libido if you have young kids and you're juggling a lot of things, but testosterone can be a really nice addition to help with many of these issues as a first line.
Good. So then typically the age of more postmenopausal women.
Probably the most common would be menopausal to postmenopausal women. Those years when you're starting to get symptoms of menopause. So you're getting a lot of hot flashes, night sweats, brain fog, irregular bleeding, um, weight gain.
And when does that start for many women?
45 to 55 is
Okay.
probably the most common time.
How about guys?
Guys, it seems to happen later. Like men, it can happen in your 50s and even in your 40s, depending on what's going on. But I would say mid 50s
Yeah,
on is probably more common for men.
got it. But typically what happens is at 40, hormone levels start going down. So that's when we should start thinking about it as patients that we could do something to help you after that time. So good. All right. If somebody wants to get started doing this, what does that look like? What do you do? Draw labs? When do they come in?
Yeah, so if anyone is interested, you can set up a consult and we will just chat with you about what your symptoms are, what your goals of care are, and then we can run various labs. It can be a complete panel that is very complete with vitamins and minerals and hormones and standard labs, or we can target certain areas that you're really concerned about. And then we'll do an initial lab review with you and, talk to you about our findings and then develop a plan of care after that to fit your specific needs.
I know when I got started on this, I don't know how you did it though, but I learned about all these things and I found, oh boy, I can be helped by these 2,700 different things. And I was all gung ho and I wanted to do it. Okay, I might be exaggerating a little bit on the 2,700, but a lot of things. And I did it for a while. And then after some period of time, I got tired of taking all these pills and then I pared it down to more. So, what I've done with me, I don't know how you do it with your patients, so too. And what I do with my patients is I ask them, well, what's the most important thing for you? What do we want to focus on? And we can give you 27 different supplements and hormones if you want to do that. Most people don't really want to do that. What are you finding with your patients?
Yeah, what I try to do is just really hone in what the labs are telling me and what the patient's telling me, and then give them suggestions in terms of what I think would be beneficial from their labs or what they're telling me, and then we discuss what is feasible. So if there's 5 supplements that could be beneficial to them based on those things, but they really just don't take supplements and they want to start with 1 or 2, then we figure out what those 1 or 2 are that they feel the most strongly about.
Yeah, that's pretty important, right there, because um, what we see from other doctors is they just look at the labs and ignore the symptoms. And hey, it's normal, but doc, I'm still having these symptoms. And no, you're normal. Leave it alone. You don't need to do anything. They're not helped. So I see that all the time. A common one for me is because I'm focusing on knees and shoulders, those kind of things with regenerative and medicine, and these topics come up because I want to know about optimizing their bodies. So then in the course of conversation, the woman will tell me, oh, yeah, I had labs done. My doctor said they were normal, but I'm so tired all the time. And then in the course of doing this, we'll add some thyroid, like T3 seems to be a really good one for this. And then they're not tired anymore. And it's just so easy to do. It's not always so easy. I want to clarify that. But it can be so easy as just adding some of these things. So that's what I see as an O, by the way, because I'm seeing them for knees and shoulders and stuff. But for you, it's different. They're seeing you
Yeah.
for all of these
But I
different
mean,
things.
for instance, thyroid can be a very interesting hormone because if you look at a lab of thyroid, when he's talking about the T3, that's the active part of thyroid. And this lab is like huge. It's like 2 to 4.5 is the range. And, you know, if you're just looking at it, quote, the normal range, right? You could be coming in in the low twos. You're considered normal, but you're tired and you don't feel well, right? So the goal is to push that up higher. And I have patients that are even above the 4.5 range for T3 because that's where they feel good. So it's not just about what a lab says, but it's also where they feel good and dialing that in.
It's really important right there, what you just said, because it's not just the labs, it's listening to the patient. What are they coming in for? What are their concerns? And so that is what we focus on, the concerns, and use the labs to help figure out what's going on with the concerns. Really, really good. I like that. Okay. So then you get the labs, you review them, you just leave them alone and say, see you in 10 years. What happens?
No, we are definitely very involved with your care, and I don't want to overdo labs, but I definitely want to check in. So it really depends on what the initial labs were and what we're concerned about. But if it's mostly just hormone optimization, then oftentimes we'll get patients. I'll get patients started on, what hormones they want to do, and then I'll do a check in around 4 to 6 weeks without more labs and just see how they're doing. And of course, with the caveat, if there's any concerns or questions or things aren't going well, to call us. And then after that time, we kind of again determine next steps if we are adjusting doses then, and then when we might. I typically will do more follow-up labs at around 3 months. And then again, depends. We're again, it's about an every 3 month check-in, at least the first year, and sooner if again, if I'm adjusting something or someone's been having problems. But, I have patients that get labs every 3 months, and I have some that get them every 6 because they're just not changing their dose very fast, or, we're just going much more slowly, and I don't want to waste their money on labs that aren't really going to be meaningful and tell us something.
Yeah, and I have patients too. Once they've been on it for years, they're stable. We get them once a year.
Yeah.
It's never less than once a year, though, especially, well, for lots of reasons. But guys, we have prostates, we can get prostate cancer. So we want to be checking that, especially if they're on testosterone. So bare minimum once a year.
Yeah, and then with women, I'll also add in, once a year suggestion of a mammogram and a pap smear and just all of the preventive things as well.
How long should people be on this for?
Well, what I've told my kids is they're going to pry out of my cold dead hands when I'm in my coffin.
Yeah.
So there is no time frame where you're too old to be on hormones. Many of what you'll hear is, oh, you should just be on it the shortest amount of time possible, or maybe 5 years, and then you have to come off. But there is no research that shows that is beneficial.
They're talking about synthetic
Yes,
hormones when those recommendations are made, totally different
different.
for bioidentical. So here's how I think of bioidentical hormones too, just to go back to that versus the synthetic. These are hormones we've had in our bodies our entire lives. From when God made us till today, we've had these in our body. So I kind of think he knows what he's doing, and we can't outsmart him by moving the hydroxyl group around on the molecule and making new ones. So yeah, those recommendations were for synthetic. Just don't do it for that long. Minimum amount of time. Synthetic. But then, how about, I'm a guy, I'm come in and I'm like, yeah, I don't know about this stuff. I'll see if it works. My wife dragged me in here. How long are you gonna recommend doing it for these people?
Well, we hope that you'll stick with us for a year, because it takes time to dial in hormones correctly and to get the right dose for you. And the longer you're on it, the better effects that you'll see over time. So we really hope you'll at least stay on it a year. And then, our goal is that you feel so good that you don't know what you were doing without them, and that you'll want to continue them lifelong.
And I'll tell people that too. So if we're doing regenerative things, I want them for a year because you can still heal from a knee procedure up to a year out. So I'll tell people a year, that's it. And then you can decide afterwards what you want to do. But I totally agree with you on the pride of my dead hands comment because you're just not getting the benefit if you stop taking them. Now, everybody will not want to do this. I'm not sure why, but people will not want to do this. And actually, I do know why. Let's talk, Merin, about my doctor said.
Yes, I was just thinking that people, the most common reason why people stop doing their hormones is they get scared. They get scared by their doctor or their neighbor. oh, you shouldn't be on those. You're going to get breast cancer. You're going to have a blood clot. You're going to have a heart attack. And that's just not true. Again, the research that was done in the past on synthetic hormones still was not even that strong in terms of, let's say, breast cancer risk, for example. Even the conjugated equine estrogen did not show an increase in breast cancer risk. It was only the synthetic progesterone that did. And there has been zero studies with estradiol and micronized progesterone that shows any increase in breast cancer risk. And in fact, what they've seen is women that are on hormones, the right kind of hormones, actually have less aggressive breast cancer if diagnosed.
Interesting. So what do you say to a woman? I just this the other day. My sister had breast cancer, but there's been no indication of breast cancer in the patient. What do you say to those people? Because they're concerned. They want to get breast cancer and they've heard all these things. What do you tell them?
All I can do is show them the research and talk to them about the risk benefit potential for these hormones, and then it's up to you ultimately. And of course, I never want to have someone go on a hormone where they're nervous or they just don't feel comfortable with it. But they've done trials even in patients with the BRCA gene, which is the gene that carries a 60 to 80% risk of getting breast cancer, and they have estradiol, they do not get increased breast cancer. Like there's
Wait,
nothing.
say that again. That's really important.
Yeah. So women, even with the gene that increases the breast cancer risk, when they have been on estradiol, they do not get more breast cancer than someone not on estradiol. They're going to get more cancer because of the BRCA gene, but there's no trials that actually show when you give estradiol, you get more cancer. So this very different in saying, oh, there might be an association with this or that, or that it's an estrogen progesterone receptor positive breast cancer. That has nothing to do with taking estradiol and getting breast cancer. Now, if you have breast cancer, we're obligated to stop your estrogen just because really medically legally we need to let oncology take over, and we just we can't do that. But if it was me or my mother, I wouldn't stop it, frankly.
So one of my friends who's a doctor in town here, she had breast cancer and treated it with estradiol. So yeah, that's not traditional, but the point is estradiol is not necessarily harmful if you get breast cancer, but you got to have a conversation and figure out
Yeah.
what you as a patient want to do if that's you.
And an interesting note is that testosterone is actually used to shrink metastatic breast cancer tumors. So there's a breast surgeon that implants testosterone pellets into the breast tissue of metastatic cancer, and she watches the tumors dissolve.
Interesting. And then what about guys? So same thing, guys with prostate cancer risk and testosterone. What do you say to them about that?
Zero increase. When you take testosterone externally, again, you do not see increased prostate cancer rates when you give testosterone. And then oftentimes the same kind of thing where you will see less aggressive prostate cancer, or often even, men that suffer from prostate hypertrophy, benign prostatic hypertrophy, BPH, actually get better when you're on testosterone. It shrinks up the prostate.
I talked to Herman Pang before he passed away. Herman is a thoracic surgeon.
Cardiothoracic.
Was a cardiothoracic surgeon, but he was very involved in a lot of these bioidentical hormones. And I talked with him about guys and prostate cancer. And he was showing me some research that shows that guys who are actually on testosterone and or estradiol decrease the risk of prostate cancer. And even guys who had prostate cancer used it to treat that. So
yes, that's a whole different topic, but definitely, I've told my husband if he got prostate cancer, I would not put him on a estrogen blocker or a testosterone blocker, which is what they use. I would just give him super high dose estradiol. And in that way, if it was metastatic, and in that way, be his prostate cancer would shrink and he wouldn't get dementia and heart disease and
yeah,
bone fractures.
Go down that road just briefly. So if you're blocking testosterone, well, if you're blocking, it's
It's essentially, yeah. When you give testosterone blockers, traditional testosterone blockers, you're actually blocking estradiol in men, which is as protective in men for the dementia, heart disease, bone health as women. So if you just block testosterone in and of itself, you're going to get all these other problems as well as not probably a lot of lifespan, on what you're doing. They might live from their prostate cancer, but they're going to die of dementia and they're going to feel horrible. So at least, it's really a discussion. If it's metastatic prostate cancer, then there is benefits to potentially lowering testosterone levels. But you can do that by giving high dose estradiol in and of itself. If it's not metastatic, then there's not necessarily even a reason to stop the testosterone. But again, that's a conversation for everybody involved.
How about a woman who's had breast cancer and now wants to start? Well, two parts of this question. First, we'll start with that one. Wants to start bioidentical hormones. What do you say to them?
Yeah, again, it's that whole conversation. And typically, if I'm being conservative, and especially if this is a new patient to me or I don't know them well, I'll wait 5 years after their original breast cancer diagnosis. They're considered cured after 5 years. And so, that's what I'll tend to do. And then some women are still really hesitant to want to do estrogen, but they want to feel better. And so some of those women will do testosterone. And that in and of itself is very helpful as well.
I've talked to numerous oncologists about this exact thing regarding our patients we're going to do regenerative things with, and we're trying to optimize them. And they've all told me too, 5 years is the magic number for that. We just have no data to support it after 5 years. So if it makes sense to do it, do it.
It doesn't make sense, but we do it because we don't want to go against colleagues in that way.
You mean we do what? What do you say?
We hold estrogen and hormones for 5 years. I don't think it makes sense to do that, but we do it because that's what the guidelines, and we're trying to kind of walk that tightrope.
That's a medical legal answer.
Yeah.
Okay. I know you wouldn't do that. Okay. How about the woman who has been on estrogen blockers? She's had breast cancer, and I know you've seen some of these patients in here too. And they just feel really, really bad. What do you tell these people?
Again, if they're in the window of the 5 years, right, and they're still heavily involved with their oncology team, then I tell them it's their choice as to whether they continue on their estrogen blocker and the reasons why it might make sense or not make sense to be on one. But I'm usually conservative as far as starting other hormones.
Yeah. It's just looking at other doctors, oncologists, what they deal with cancer. It's the big secret. Everybody's afraid of that. Nobody wants to get cancer. So they're going to give every reason they can to not have, or to do whatever they can to not have the cancer come back. And they're never going to say it's okay to not do the blockers, or it's okay to do estradiol. It's just never going to happen. But the women just feel really bad when they're on it. And I know it's a good discussion to have with people. Hey, you're the patient. You get to decide what you want to do. I can't tell you what to do.
And maybe really, really looking at the hard data on the true benefits of estrogen blockers.
Yeah. That's longer than I wanted to spend on that, but that was good. So, okay. Now we got a good overview of the symptoms, what people can do if they want to start looking into this process of optimizing their hormones. And you want to say anything else about?
No, I would just say, if you can see this, we do have a book in the clinic that is fresh off the press, and it's called Normal Isn't Optimal by Dr. Rouzier. And we sell them in the clinic for $20, but you can also get them online. And this book will back up kind of the discussions that we had today as well.
Yeah, that's for all you overachievers who want to learn way more about this stuff. It's actually a really good book too. And just remember, we're talking about this optimization concept, which is good for so many reasons. And for us here, we're using it a lot of times in the overall program of what do we do to help your knee, and we call it look ma no stitches, stitches, and it's just a part of a comprehensive program, just one part of it. And there's other things we can do too. So it's the regenerative orthopedics, which is using PRP, fat, bone marrow to help knees, shoulders, whatever body part it is we're talking about. And then this is what we're talking about here now, the optimization. It's part of our biobalance program, which is the optimization, but also could be combined with weight loss and muscle building as well. And then the last one we have is a body blitz program here, where it's weight loss and muscle building. So these are all programs that we have here that can help optimize your body. So, Merin, if somebody wants to make an appointment with you, what do they do?
Okay, now I remember the phone number. I always forget the phone number because I don't call it. But you can definitely call our office at 385
220.
220-9909. Again, don't call it, but please call, make an appointment. I'm happy to you can just come in and just do a consult, and we can just talk about your concerns, and we can let you know if we can help you.
Yeah, that's it. Just give us a call if you have any questions, want to talk to Merin. It's great. So she's our expert in this. Yes, I do some of this, but she's better than me.
I'm better.
So, yeah, she is. Okay, so thank you, Merin, very much for spending some time with us here today and just educating people on optimizing their hormones and why be normal. There's no reason to be normal.
No reason.
We want to be optimal. Thanks for listening to Live Better Without Surgery. I hope you found today's discussion enlightening and empowering. Keep in mind that non-surgical alternatives can lead to a healthier, happier you. Until next time, live better without surgery.